So, good morning, everybody. Well, it's early morning for us and it's a bit late afternoon for our guest today. So I'm really excited. I'm with Marianne today. I'm always really excited, but today we have Michelle Telfer with us. Michelle is a paediatrician doctor in Australia, and she does a lot of work with trans children. As always, I'll hand over to you, Michelle, to introduce yourself. Tell us who you are, what you do, how you ended up doing this line of work, everything about you. So over to you to introduce yourself.
Thanks, Helen. I don't think you want to know everything about me, but I am Michelle Telfer. I'm a paediatrician and adolescent physician, and I work at the Royal Children's Hospital in Melbourne in Australia. And I'm director of the Department of Adolescent Medicine, and within that department I'm also the director of the RCH Gender Service, which is a service that's grown over the last 17 years to now be a team of approximately 16 people that look after trans, gender diverse and non-binary young people from about the age of 3 up until we accept referrals up to the age of 17. But we do provide care until we can transition young people into adult health services around early adulthood. So I, talking about everything about me, I was actually born in Perth, which is across the other side of the country in Western Australia. It's actually one of the most isolated cities in the world, and moved to Melbourne after I finished university in 2001. Or I actually moved in 2002, but around a long time ago anyway, and have been at the Royal Children's Hospital here since 2003. So I am what they call a Melburnian, but also claim to be West Australian as well. Have shoes in both camps, so to speak.
Thank you, brilliant. So you said 17 years ago, and that's when you joined. So was this service up and running then, or is this something that you've been instrumental in developing as more and more, obviously more and more people have come forward as being trans or over the last few years? So is it a service that you've developed, or was it already in place, kind of thing?
Yeah, well, I actually didn't join the service until 2012. So when I came to the Royal Children's Hospital in 2003, I was a very junior paediatric resident, really just starting my specialty training. And it was around that time that the Royal Children's Hospital had its first ever young person who presented to the hospital needing care. And this young person was about 12 when they presented, and came with a complicated story that involved identifying as trans and really needing to transition to support their mental health. And one of the endocrinologists at that time, Professor Gary Warren, saw this young person in collaboration with a child and adolescent psychiatrist called Associate Professor Campbell Paul. And the two of them provided care for this young person who did go on to transition medically and do very well, actually, despite his challenges. It was 2 years after that the Royal Children's received their second young person, their second referral for someone wanting care, and then 2 years after that they received the third referral. So when I came in as an adolescent medicine specialist in 2012, so having done my paediatric and specialty training between 2003 and that time, I took over as the clinical lead in adolescent medicine. And it was that time that Gary Warren, the paediatric endocrinologist, actually retired. And with his retirement, there wasn't someone to take over from his role, providing support for medical transition. And that's when I put my hand up to help out. And what was really, what's been really interesting is in 2012, that year we had 18 new referrals. So it was still relatively small. And there wasn't a structure around the service. I don't know that you'd even call it a service. It was more a couple of clinicians who were providing care for these young people who were presenting wanting that assistance. But between 2012, when I joined and joined the team, where there was only sort of 3 or 4 of us, to 2019, we've had such enormous increases in demand that last year we had 336 new referrals. So it's gone from a very small kind of group of interested clinicians into now a multidisciplinary service that is very much structured, protocolised, supported by many clinicians who bring their own expertise, but with the structure that's required to provide good care to such a large number of young people.
Yeah.
So over that time, we would have had 1,500 young people come through the service.
It's amazing, isn't it? I mean, I think across the world we've seen that increase, and I love the way that you explained the first patient, and you said, you know, needing to transition to support their mental health, and it's a really interesting way of thinking about it, isn't it? Because you know there will be people who say, well, they don't need to transition. What's wrong with just staying in their birth assigned gender? But actually, it is about their mental health, isn't it? And you know, this is a need. This is something that needs to happen in order for them to live a comfortable and happy life very often. So I love the way that you said that. So, I mean, we were really delighted when you produced the Australian Standards of Care in 2018. You know, the world is crying out for documents and guidelines like that. And I have to say, it's a fantastic document. Thank you for doing that. So, but really, I mean, I'm guessing from 2012 to 2018, when you wrote that, you kind of, what were you basing your medicine on? Because that's often been a criticism at us, isn't it? You know, how do you know it's the right thing to do? How do you know it's safe? How did you as a department and a team approach that?
Yeah, it's a good question. When I joined the team, I didn't know very much at all. I was really quite naive with regards to this area of medicine. It's not something that we learnt about in medical school. I had very little exposure during my training in paediatrics even, and adolescent medicine. So when I was approached by the hospital to take over Gary's position, I had to do a lot of reading, and I went to a number of events and conferences to hear the experts speak. But certainly looking at the evidence is very much overwhelmingly in favour of affirmative care, and the evidence also really well documents the damage that is done with either denial of that care, or even in a worst case scenario, an active denial or conversion type response in terms of not providing that care. And I was really struck by the young people I was seeing, and just anecdotally how strong the affirmative stance was in terms of producing really good outcomes. Like at an individual level, you could see the power of allowing a young person to express who they are, and supporting them in being who they know themselves to be. You could see in front of your eyes the way that the young person would thrive and bloom, and taking the evidence in the larger trials and putting it into practice at an individual level, for me, was really eye-opening. And there aren't that many areas of medicine that you can see that difference so profoundly, especially in terms of the work that we do just in talking to young people. But this was an area that I could really feel how rewarding it was to just support young people to be themselves. And so I'm going totally off the question, but the reason for bringing this up was that what I was reading in terms of the journals and what I was hearing from the experts, we were putting in practice with these young people that we were seeing. And it was extraordinary to see the great outcomes that could come with this. And when I compared that at an individual level with the families who weren't supportive of the young person, just the pain that was experienced by this young person not being able to thrive, not being able to meet their potential in any aspect of their life, whether that was socially, emotionally, educationally, or just in general family function, that it was so clear that supporting this young person, they do really well. Not supporting or actively showing unsupportive behaviour towards that young person was catastrophic for their outcome. So I guess what we did as a team was initially to follow the WPATH guidelines and to use those guidelines plus the evidence we had in moving forward from those guidelines, because as you know, the WPATH guidelines were published in 2011, and whilst they were the most progressive guidelines in 2011, between 2011 and 2018 there was a lot of change and a lot of evidence that was coming out that was suggesting that a chronological age used to decide when someone should start hormone treatment, for example, was not necessarily in a young person's best interest. And we saw the benefits through the data, so through teams like that in like Arnaud de Vries in the Netherlands and others, that for some young people needing to transition medically a bit earlier was really helpful for them, whether it was reducing side effects for blockers or from blockers, or improving their psychosocial outcomes from being able to being able to go through puberty with their peers. Whatever those risks and benefits were weighed up on an individual level, we could improve their outcomes. And I'm not sure if you want me to go into the detail of why we started writing the guidelines, but it has its origins actually in the evidence and how we were moving forward. We had a really unique situation in Australia where we had a law that essentially, this law that was created through case law in 2004 was a case known as Alex, and this case involved a young person who wasn't living with their parents, and who was actually living in the care of the state. And this young person needed to transition medically, but was too young to consent themselves. They were only 12 at the time when they were really needing to go onto blockers. So they couldn't consent themselves. Legally, they weren't able to consent. They didn't have any parents to provide consent, and the state or the government really wasn't sure about providing consent on their own. So what normally happens in Australia in this situation is it goes to the family court, which is a federal court, and the court will make an order based on the best interest of the child. And that's what happened in this case, is that Alex went to court, and evidence was put forward by his treating clinicians and some overseas experts. And the judge in this case made an order that Alex could progress with using puberty suppression followed by testosterone treatment. But unfortunately, the judge in his orders concluded that the situation warranted in the future others coming to court for this same treatment. Yeah. And what that did was set up a precedent where everyone under the age of 18 in Australia needed to approach the court for hormone treatment. And in time, and I do genuinely think that the judge thought that this would be in the best interest of young people, but clearly as society became much more accepting of trans young people and recognised the need for them to transition during adolescence, also with the numbers coming forward because of acceptance and because of trans visibility and all the great things that we've seen over recent years, because more and more young people were coming forward, the court was seeing more and more cases. And this court process in itself was really damaging.
Yeah.
There was a study done by a professor of law, Fiona Kelly, who's also based in Melbourne, and she did a study looking at families who'd have to traverse the family court to get hormone treatment for their children. And what she showed in that piece of research was that it caused a huge amount of distress for the young people and the families. They often found that their mental health suffered most leading up to the court date, because obviously having your own information put out in a public forum, even if it's de-identified, it's still your information that's being put out into the public arena. You put before a judge who you've never met before, making a decision around your life that is probably, I suspect, the most important thing to you at that point in time. And it's so key to who you are and just who you are. And you've got a judge making this decision. Plus, it was causing a delay to treatment of about 8 months. And for some families who weren't able to get pro bono representation, it was costing up to 30,000 Australian dollars.
Wow.
So it was a huge impediment to accessing care. And we really needed to do something about it because it was causing so much harm. And between the time of 2004 and 2017, the court had heard approximately 67 cases. Many more young people had wanted care during that time, but had opted to wait until they turned 18 to avoid the court system. And I suspect a large number of young people outside of capital cities, especially in other places where accessing court was not possible, that they were potentially even accessing medication through other means. But over this time of the 60 plus cases that were heard, there wasn't one case where the judge didn't produce an order to provide hormone treatment for the young person in front of them. And of course, over time too, when you have so many young people coming forward with similar history of how they feel and what they need, and similar experiences in terms of the desire to transition and the need to transition, that there was a bit of unease within the judicial system that this was not right, and that this was not in the best interests of young people. And it's discriminatory because there aren't other situations like this where totally competent young people who are requesting an evidence-based treatment that is in their best interest would ever need to go to court, especially if the young person, the parents and the clinicians looking after them all agreed it was in their best interest. So there was a campaign to try and remove this process from the court system and have the clinicians be making the decisions in conjunction, of course, with the young person and their family. And this is a very long story to get to my point, but during the advocacy, what became clear was that there were a number of judges and lawyers and politicians who said, if the court isn't providing good governance over these decisions, medical decisions, then how are we going to maintain good governance? How are we going to maintain consistency and ensure that these young people are receiving the best care? And normally in medical circles, as you know, we would follow clinical guidelines. But what had happened between 2011 and 2017 was that the judges were also recognising that for some young people, 16 was too late to start hormone treatment. They might have been started on puberty blockers from age 10, and to wait 6 years had consequences in terms of their bone density and in terms of the delay for pubertal experience with their peers. And we'd gone to court at an earlier age to seek approval, and the judges had given approval for young people to start hormone treatment. A number of young people had started treatment at 15 outside of the WPATH guidelines. And one of the difficulties in trying to reach a point of change was we realised that we needed to have new guidelines, and we needed to actually reflect clinical practice in our guidelines. And in a search around the world, there weren't guidelines that we could say that we were following that were evidence-based and reflected best practice. So being Australian, you know, we have that kind of, or we like to think we have this larrikin element where we just go, right, well, we just have to make our own, we'll just do our own. And so we put the guideline together. It took many months, and it was a collaboration across the country and included some clinicians from New Zealand. It was the guidelines were also involved a number of children, adolescents, their parents, their siblings, and went through various stages and a number of drafts involving everybody. And then eventually we had the standards of care that we were happy with, that we had consensus for, and that reflected the work that we did in Australia. And these were put forward really for the reason of court reform, but also because it was felt that we really did need to have a guideline that provided that governance in what we do. So it served a number of purposes, and there was a case that was heard in Australia. It was heard in Sydney, called Re-Kelvin, and I was the medical expert called for that case to provide evidence, and I was certainly able to put forward the Australian standards of care into evidence as what is best practice internationally, what is conducted internationally by the services that we feel follow evidence-informed care, and a consequence of putting it out into the public forum and later having it published in the Medical Journal of Australia exposed it to others internationally, and the response was amazing. I was actually I genuinely hadn't thought of the potential impact at an international level. That was never the intention, but it really did have an incredible response, which wasn't harmed at all by the fact that the Lancet, and I might just say that word again, the Lancet picked it up and did an editorial on it. And I nearly fell off my chair when they first contacted me, because I was genuinely really shocked. But there was obviously a need there. That people wanted to be able to provide good individualised care that really did look at what was the best treatment options for the young person in front of them, And I think our guidelines allow that flexibility whilst also keeping containment in terms of care that's within the evidence base.
Yeah. I think for me as a doctor, what it's given us is permission. You know, it reflects, it's written, I think, in a very friendly way. And I think it gives permission to those people and clinicians who kind of have that gut feeling that this is the right thing to do, but nothing to back it up with. And that's what was missing, wasn't it? So it actually gives permission. And I think probably internationally, people were doing this in their day-to-day practice because they understood it was the right thing to do, but perhaps just being a bit quiet about it because there wasn't that backup. And so now to have that backup is amazing. And, you know, the first thing that I do, and when anything like this comes out, is I scan it and say, please don't use the word 16, please don't use the word 16, because that 16 word is such a misnomer. It just shouldn't be in there. You know, why does anyone have to wait till 16 to have their life progress, you know? And we've, you know, I think around this room, all of us have had teenagers who teenagehood starts earlier than 16. That 16 is just such a wrong number. I'm going to bring Marianne in here. Marianne, you were a child who didn't have access to this kind of evidence-based, compassionate, experienced care. What do you think it would have done for you if this kind of attitude had been around when you were young?
Oh, wow. Yeah. Firstly, I just wanted to say fascinating to see how it's developed, and actually lovely to hear what the response is. I don't get involved in all of that side. I just see the people in front of me. But yeah, just to see how the social change has happened since my childhood, there wasn't even a conversation. And now there is genuine care out there. It would just have been mind-blowing how many lives would have been different, how many lives would have been more fulfilled. And the one thing as Helen knows, and anybody at GenderGP knows, my passion is for the youth, not because I don't care about the adults, but actually I see what the result is when they didn't get care as children. I was really fortunate from keeping my own mental health and life together and functioning, but so many aren't. So if we don't look after the youth now, we're just going to have another generation of adults that have got missed opportunities, lives not fulfilled, you know, potential not fulfilled. So hearing what's happened in Australia in a recent time, and the just before I finish, the sad part is I haven't a clue how this has developed in the UK, because the Tavistock have kept hold of everything, if I'm allowed to name the Tavistock. But the truth of the matter is, you know, the care in the UK feels like it's from a NHS level is held back 20 years. And everything I heard you saying there is very 2018, 2020. Which is refreshing to hear. Hopefully others will be hearing your story. It's
Michelle, I don't know if you know much about my situation, but I was going to say I stumbled into this arena. Maybe I did. In 2015, I was a excuse me, a GP and a sexual health doctor, and I started seeing, that was around the time when people were beginning to come forward more, not youth but adults, so in my everyday practice, people were coming to me saying, you know, can you help me? You're the kind of doctor that I can talk to. Can you help me? And there was just nothing, you know, like a bit like you. I didn't have any experience really in that area. And then when I started seeing what was happening, I was like, goodness gracious, you know, this is an area of healthcare that if we spoke about this, people wouldn't believe the patient experience that's going on. And I was really shocked, really, really, really shocked. And so GenderGP was founded as a kind of, it started off as an advice place. You know, if you're trans, this is what you are entitled to. This is the healthcare that you deserve. You should be able to ask for this kind of thing. And it wasn't before long it became a, you know, as a doctor, you know, you have people coming to you saying, well, you're a doctor, can you help me? You know, you seem to understand, can you help me? And then it wasn't long before the young people started coming, and they're like, well, if you're helping these adults, could you help me? And I'm like, well, I don't see why not, because I'm just like you know how you described it earlier. I was just seeing what benefit giving gender affirming care it was helping people, astoundingly helping people. It's transforming their lives. And as a doctor, like, exactly as you said, you know, you coined my words off that I say often. You don't get that chance in medicine very often to make that much of a difference. And I was loving it. I was absolutely loving it. You know, helping people, learning, reading everything I could possibly read, helping people and transforming lives. I was just in my element. And then, like, this sword came down where my colleagues in the UK were like, well, that's not the way we do it. We don't do it like that. And we haven't ever done it like that. And we don't like you coming in to do it like this. And so actually we're going to refer you to your regulator, which is our General Medical Council. So I had a flurry of, they didn't like pick the phone up to me. They just, they wrote letters to the GMC and said, this doctor's, you know, negligent, this doctor's behaving not the way that we behave, and you need to do something about it. So in 2000 and, where are we now? So it's coming up 4 years. So 2017, May 2017, I was stopped from working, and I haven't been able to work since because of providing care that I could see was happening across the world, internationally. I could see other doctors doing exactly what I was doing, but because we don't do it in the UK, I was stopped. And you're supposed to be stopped for 6 months while they just check it out. 4 years later, they're still kind of checking it out. And, you know, it's really heartbreaking to have your career taken away from you for doing something that you feel so passionate about. And, you know, I think many people have said to me along the way, well, why don't you just give up? You know, just go back, well, I can't go back because I'm still unable to practice, but, you know, why don't you just stop, give up? Is it worth it? All the tears, the heartache and everything. But I think you only got to see a few of those young faces that you've been able to help, and transform, enable, and, you know, it's not something that I can give up. I mean, and I think, you know, I'm not the only doctor across the world who's taken these brave steps forward and received criticism. But I think for me, the fact that it was criticism from my colleagues that has caused this difficulty for me is really, really difficult. And I think, Marianne, you know, you said that it seems that the NHS and the UK are 20 years behind, and it really does feel like that, you know. And I'm envious, Michelle, of your beautiful guidelines, and envious that you have a working place where actually it's absolutely fine to give care to youth under the age of 16, because this is what enables them to, as you said, socially, emotionally, and educationally move on and have an adolescence with their peers. So it's challenging. We see it across the world. You know, we see it on social media, we see it in the newspapers, we see it everywhere. The challenges that I think brave women like you, myself, and of course Joanna in America have faced. But, you know, I think we have to continue bravely forward, don't we?
Absolutely. I'm so sorry to hear that. It's a devastating story, an absolutely devastating story. And I can't imagine having my career taken away from me in a way that's so profoundly, what's the word, unfair and misguided, because I'm a bit speechless actually, because when you are going about your work really to help young people, and when you know you're helping young people, to have that to be removed is, that's so awful. That's really awful. I don't really know what to say because it's. No,
I just, I suppose, you know, thank you. But I think at the point I was making is that this is a challenge, but in order to effect change in our lifetime as clinicians, you know, we have to sometimes have some battles on behalf of our patients, don't we? And
I mean, it's a human rights issue. It is absolutely a human rights issue that we all have a right to healthcare, whether we are trans, cis, or anyone. We all have an equal right to healthcare, and to think that we can differentiate people based on their gender is just outright discrimination, and it's appalling.
yeah.
And it's worth a fight. It is absolutely worth a fight when you, as you say, when you see the benefits, when you see it so starkly evident in front of you. It is something that is worth fighting for, and you feel that in your bones. And I think, yeah, we've all got to keep up the fight for what's right. But it does come at a personal cost, clearly.
It does. But it's a fight worth having. Marianne, were you going to say something? Sorry,
a question coming into my mind is the care in Australia, or at least in Melbourne, is that funded by the state, or is it insurance based?
Yeah, so we're very fortunate in Australia that we have universal healthcare. So it's very similar to the NHS. We have Medicare, and for young people across Australia, there are a number of state-funded gender services that will provide all care based under Medicare, so will be for free. And that doesn't include any surgical care, but in terms of the mental health care, the medical care, and the cost of puberty suppression, the state does provide that.
The reason I asked the question is that I'm not sure whether I've observed right, but I think in countries where the state's not necessarily funding it, the backlash from the media tends to be less than where, you know, all we get in the UK is, you know, this is taxpayers' money. We've got a right, you know, to influence this. And I think that's probably holding people back. You know, once we've got a social movement against what you're trying to do, then I think it holds progression back. I was just wondering whether that's the same in Australia, but it doesn't sound like it is at the moment.
No, well, we've got a very progressive government in Victoria. So the Victorian government, which is the state that Melbourne is the capital of, our government is extremely progressive and has been the greatest supporter of the RCH gender service, and they were this particular government that's still in power now gave us the first big grant of $6 million over 4 years to expand the team to cope with the rising demand. And we've just had our federal health minister also endorse gender affirming healthcare across the country. And the federal health minister, Minister Hunt, is a minister within the Conservative government, but he has been able to look at the evidence, be advised on the evidence, and has made a statement just in the last fortnight about the benefits of gender affirming care. And he has made two particular recommendations, one being that care should be accessible equally across the country, and that we need further funding for research to improve outcomes for transgender diverse young people. So I think we're very fortunate with governments who will listen to experts and will make decisions based on evidence. And what we've seen overseas, I guess where things are difficult, even where care isn't necessarily state funded in the US, there are really strong anti-trans movements there too. So yeah, I think there are lots of factors. We just feel very fortunate in Australia that we've got supportive governments who recognise the need for supporting these young people in a way that's in a way that has the best outcomes.
Yeah, that's amazing. You know, I think that's yeah, that's a very, very positive help and support for you, which is lovely.
I feel like I'm bombarding you with questions here, Michelle, so I
Oh,
apologise.
please do. Yeah, go ahead.
But actually, you've said there's 350 referrals to you. Was it last year or hopefully not?
Yes, 2019. Yeah.
Is that just in the state of Victoria then?
Yes, that's just in the state of Victoria.
Yeah. So I'm just trying to wonder what the magnitude of that is, you know, per population. But I would imagine it's quite a lot, that actually, considering the numbers we're given for the whole country in the UK, which is obviously far greater populated.
Yeah.
That still sounds like a lot.
Yeah, I'm not sure I'm going to get these numbers totally correct off the top of my head, but there have been two key studies done, one in New Zealand and one in Australia, looking at prevalence of young people who identify as trans and gender diverse. The one from Australia was done only in the last year or 18 months perhaps, and it was a secondary school survey looking at young people in mid to late adolescence, and 2.3% identified as trans or gender diverse, and which is consistent with the New Zealand study, which also had about 6,000 secondary school students taken from across New Zealand, so a good representative large sample. And they showed that it was 1.2% identified as transgender, and 2.5% said they were unsure of their gender identity, or and another percentage didn't understand the question. So if you think about trans and gender diverse young people as a whole, it's probably sitting around 2.3, 2.5%. We still have lots of barriers to accessing care in Australia that relate to socioeconomic disadvantage, those that are in rural and regional areas where they don't necessarily have the same supports, and certain groups that are culturally and linguistically diverse, who also probably find it much more difficult to access care for concerns about their gender. So I don't think our numbers yet reflect the actual population, but we know that that with increasing societal acceptance and visibility and education around diversity, and improving in areas of the human rights aspect of care generally, that the numbers will continue to increase until we get to a point where we can be confident that those that are needing care are actually accessing that care.
Yeah. Your general practice, primary care, what term you use in Australia, because part of the big work that we do is trying to educate and empower primary care doctors and nurses and help anyone in that team to help young people and older people, because we have a very, very much super specialist tier system here, which clearly is not coping with that increase in numbers, and so the waiting lists are huge, absolutely huge, and the damage that happens in that time, you know, is hideous. Opportunities missed galore. So a lot of our work is trying to empower primary care to take these steps, you know, and the first time you prescribe a puberty blocker for a young person, it's quite scary, you know, there's no doubt about it, it's scary, but then when you see the benefit of that, it's amazing. So what's it like where you are, you know, is it extending out into primary care now, or not yet?
Yeah, that's a good question. So my feeling is that we really do need to expand into primary care for services to be sustainable. There's no doubt about that. And how we've gone about it so far is that we've we do believe that having a multidisciplinary care model is best practice, and there are opportunities to combine general practitioners in primary care with psychologists and other mental health specialists to work together to provide good care, and not diminishing the expertise of general practitioners in providing mental health care. But what we find in Australia is that the way things are funded is that general practitioners don't often have enough time to provide the input that young people might need with their families around some of these decisions. So what we've been doing, because we've been fortunate with our funding up until recently, when we have had things better under control in terms of waiting lists. When we've had a young person who's come to us and is receiving care from us, we've brought the GP into that care as a shared care type arrangement. So, for example, if I have a young person on testosterone injections every 3 months, they might have one injection at their GP and a follow-up review with their GP, and then see me only every 6 months for every second. And that way we've been able to not only upskill GPs, but also to educate more broadly with the practice there. So getting people comfortable, like the nursing staff in that practice providing injections, for example. They may have a psychologist within that practice that young person may also see if they need some extra support with especially the young people that have depression, anxiety, or other related difficulties. So we've gone about things in a shared care arrangement. But I think you're right. It is really anxiety provoking for GPs generally, or primary care physicians. We tend to call them general practitioners here, but also I think it's going to take some time, because none of us were taught much about providing care for trans and gender diverse young people when we were at university. And medical students now are only just starting to get the education, and probably aren't getting enough education to feel comfortable to be able to do this when they become doctors working in the community. So we need to approach it at different levels and all work together. But expansion of services into primary care really will have to happen over time to ensure sustainability. I'm not sure how the UK has managed the demand in adult services. You could probably give me more detail on that, but we know in Australia there has been expansion into primary care, and there are a number of specialist primary care practices in Melbourne, 3 in particular, that predominantly provide care for the trans community, and that's been working really well. One particular specialty practice is known as Equinox, and that was set up by the trans community for the trans community, and it's mostly bulk billed through Medicare, and they have mental health clinicians, they have general practitioners, they have peer navigators and others assisting in providing care for the adult population, and that's working really well. And I suspect that that will be the direction things go in generally. Yeah.
I think in the UK, I mean, in 2016, our Women and Equalities government body did a report, and they really dug deep to find out what the trans experience was in the UK. And I think it obviously uncovered some shocking truths. And I think it's fear, isn't it, Michelle? I think when you're not educated in something and you don't know anything about it, and then you're asked to be an expert, because doctors are experts in people's health, and so you're asked to be an expert in something that you have no training, no education, and maybe even some personal belief about, and then you're asked to help, and that's scary. And so you've got there's two things you can do. You can just back away and go, I'm not looking, I'm not touching, absolutely no. Or you can go, actually, well, let me read about it. And I don't think we have the support in the UK that you've been describing, not from government or from our regulatory bodies. And actually, if you Google what happens to doctors who help trans people in the UK, it's not been a good history. So it's not surprising for me that doctors are scared and are taking the opposite approach, which is, no, I'm not. No way am I going to dip my toe in this. I'm going to keep myself safe. But the problem is that means that all those trans patients are not safe, and that's really sad. And I think the other thing that's probably happening is that the doctors who are feeling comfortable enough to do something are not speaking about it for fear of being in some way told off, or you shouldn't be doing that, you're not qualified to do that. And so maybe they're actually working in a quite isolated way, and not supported because they're not really coming forward to bravely say, I'm doing this. So we've got a lot of work to do in the UK, I think, to move forward, and it also means that there are no guidelines. We have I don't know whether we have NICE, which is the National Institute of Clinical Excellence in the UK, which governs a lot of what we do. And I wrote to them last year and said, what have you got in the pipelines for transgender health? And they said, sorry, nothing. So it's like it feels like we haven't even started to create our own guidelines. And I'm quite, the UK is, from my point of view, has always been a forward-thinking nation. We're up there, and yet it just feels in this particular field of healthcare, of society, of life, that we're very, very backward, and I'm quite ashamed of that, really. We've been working on some guidelines actually for GPs, not necessarily how to treat somebody, not really medical, but just, am I allowed to? If an adult comes to me and says, please, can you give me some estrogen instead of this horrible testosterone I've got? Would that be okay? And it's just like, am I allowed to do that as a doctor? And so we've been working on that guideline. And I think the other thing for us, going back to the youth, is that the waiting times here are at least 2 years from when you, not from when you go to your GP, because often when you go to your GP, there's a delay in persuading your GP that you need a referral. And then when you do get referred, you have to wait at least 2 years to start the assessment process as a young person in the UK. And then if in that time you teeter towards 17, you're moved on to adult services without even starting. So if you're going to your GP at 14 and a half, say, and kind of battling till 15, and then you're not going to get any care at all until you're 20, kind of thing. And we all know what benefit stopping puberty, or just putting puberty on hold, can do. And Marianne, this goes a little bit back to what you were saying earlier, isn't it? If we can just press pause on puberty and give these kids a minute without that testosterone or estrogen raging through and causing those changes, just a minute. And I feel personally, as a GP, that is well within the realms of capability of a GP, and it would make such a difference to so many people in the UK. So for me, it's about education and about permission, which is why I'm fighting this battle, my personal regulatory battle, right to the end. And I think, well, I don't know, COVID's come in and upset timings, but I was hoping that it would be complete this year, but I'm guessing now it won't be complete till next year. And if that's not successful, then we will go to the High Court and the Supreme Court, because it's a really, this permission. As a doctor, are you allowed to provide care for trans people of all ages? And I think that answer should 100% be yes. And that's why, we'll carry on with this battle. So yes, for me, it's about education and permission, and that's key. And I'm encouraged to hear that in your medical schools that education is starting. I hope so too. We have a medical student on our team who's a real flag flyer, and she's been writing and educating in her medical school. So I'm hoping that the future will be better for education. But
yes. We've had a number of groups within without the university that I work within. So I have an appointment with the University of Melbourne, and they've held lectures for medical students for quite a number of years now, and the medical students themselves often opt to come and be be attached to our unit so that they get some hands-on experience. It's been fantastic just to see the enthusiasm there. And I can see that with time, we will eventually get to that point. But having situations like yours, Helen, where people see clinicians being targeted, whether it's through colleagues or whether it's in the press, you can see why people become afraid, and why they might be reluctant to get into what is a very, very rewarding area of medicine. And the other thing about when we were going through medical school, and even certainly in my younger years, learning to be a doctor, there's an expectation that you are in control, that you are an expert, that you have the answers, and for doctors to go into an area where they might not initially be comfortable, that they don't know the answers, that there is a need to sit with a certain level of uncertainty. I think that's with adolescent medicine generally, not just in this area, but in many areas of adolescent medicine, we have to sit with uncertainty. And they're skills that need time to be developed. And really one needs to be well supported to go into an area that is new and is complex. So I agree with everything you said there.
I was just going to kind of umbrella everything that I'm hearing, obviously two clinicians talking. I think being a member of the trans community, what I see is there's a social shift going on. And I think what's happened to you, Helen, and please tell me if I'm wrong, but I think we're caught up in a crossfire between evidence-based medicine and how the public feel about it. And I think that, unfortunately, is filtering through into the politics, which then filters through into the medical authorities. And that makes everybody nervous then. So if you've got a doctor that is exploring a new area of medicine and everybody else is going, oh, are you sure? It's kind of going to filter through, everything in society. So I think it's balancing, no education around gender diversity within schools isn't helping. It should have started 40 years ago. This isn't new, but it's not even starting now. And I think that's the battle that the trans community is facing, that we're now hitting the obstacles that we should have been hitting over the last 40 years, but they've all come together, if that makes sense.
It has, and also I think what you were talking about, the way that society has its view, and that filters into the powers that be. Excuse me. And what's missing is the voices that Michelle has put into the standards of care, and that's the voices of the young people, the voices of the trans community, because they taught me everything. They taught me absolutely everything I know, and then I backed that knowledge up with reading the medical science. That was the bit that I can do because I'm medically trained, and I sometimes just want to parade, a bunch of trans youth in front of these people who are making decisions at such a high level about what happens to them, and say, look at these youngsters, look how happy and successful they are because they've had gender affirming care. And then if you want to, have a look at those ones that have been denied it, and look at the difference, and tell me that it doesn't make a difference to provide the care that's needed. So yes, I feel a bit passionate about that. You can probably tell.
That's great. One of the things that you said, Marianne, with regards to the public's view on this, is that my feeling in Australia is that the vast majority of people understand diversity and are accepting of diversity, and that the pushback that we've seen in terms of supporting trans young people is really driven by what is likely to be a much smaller group, but they're powerful, and they're loud, and they have access to ways of amplifying their views, whether it's through certain aspects of the press and media outlets. But the response that I get within Melbourne and Victoria and more broadly, generally, is really supportive of trans youth, and I think it's about continuing on with doing what's right, continuing on despite some of that negativity that is not based on the evidence. It's not based on an informed view, and continuing to help what are really vulnerable population.
I agree entirely. I think even in the UK, I talk about two different things: what I read in the newspapers and what I feel on the street.
Yeah.
And it couldn't be more different. I'm not going to kid myself that there isn't an element of tension depending on where I am. But I go out and I buy my coffee and sit in the cafes and go in the shops, and nobody's ever stopped me, nobody's hesitated. So what I experience and what I read in the paper, they're a world apart. But I think the trouble is, the more it's fed into the paper, then it makes more trans people nervous, that the visibility becomes a little bit less. And then what we start getting is mental health issues because people are repressing. And then what we start saying, oh, well, trans people are all crazy. Do you know what I mean? That's because we've created an environment. But no, I think you're right. I don't think it's whether people are accepting of diversity. I think people just think, let live and let live. I might not understand it, but, I don't know this person. Why have I got a problem with them? But that small group are the ones that are getting the attention.
Well, thank you for joining us today, Michelle. It's been really lovely to talk to someone, from so far across the world, but in a similar field to mine. It's lovely to talk to you, because it's hard to. I think there's so few clinicians working in this field in such an affirmative way. That's what it feels like to me, anyway. That it's been really lovely to talk to you, and thank you for sharing. The development of the Australian standards of care. We are so glad that you did that. So even if you thought it was just going to be for local use only, it definitely isn't. It's an amazing document, and thank you and all the people that contributed to that for helping give us that permission in an evidence-based way, and also understanding that the evidence, okay, we have plenty of evidence. So there's so many people saying we don't. We do have plenty of evidence, but it's bringing as well that personal case report into it as well, which is really vital. So thank you for doing that, and thank you for joining us today.
Thank you.
I hope that people listening have enjoyed it.
Thank you for having me on your program, Helen, and nice to meet you, Marianne.
Likewise.
Thanks very much. Bye-bye.
Bye.